My name is Dan van Este. I'm a radiation oncologist in Ghent University and also a consultant brachytherapy in the Mastro Clinic. So it's in Belgium and in the Netherlands. And I'd like to share with you two topics today. One is about focal therapy and the other is about a teaching platform on biopsies and fiducial markers. So this is the small overview of this first talk. Why should you do focal therapy? How you should do it and which kind of selection of patients you should do it. Transperineal biopsies are very important in that particular case. How you should plan and some small conclusions. So why should you do focal therapy? Nowadays, the strategy is surveillance versus radical whole gland therapy. But the radical whole organ treatments have significant comorbidities. So the incontinence rates are from surgery up to 24% on 1 to 2 years. Radiation proctitis, it's varying depending which kind of series you're using, but it's depending between 10 to 20%. And erectile dysfunction is also an important issue that is 70 to 82%. So to downsize these side effects, you can downsize your irradiated volume and using focal therapy. Is post-radiotherapy GI toxicity still a clinical issue? Chronic radiation proctitis varies, like I mentioned. On the left side, you see like the grade 1, what is most often. Grade 2 is still varying between 10 to 20%. And then grade 3 and 4, luckily, we don't see that often anymore. So how can we do a focal therapy? There are several approaches that you can do. So you can solely treat the target ablation. So that's the tumor, the clinical significant tumor with a small margin. Or you can use the hemiablation. So that's in the middle. So that's like that you do a part of the prostate. Or you do the zonal ablations. There are several techniques available now. You can use HIFU, cryo, PDT, or laser, like our colleagues urologists are often using, but they are not that proven as an anti-cancer treatment. So brachytherapy is the optimal treatment to do a focal treatment. Like the previous speaker already told, that brachytherapy is the ultimate method to dose escalate. So what you see is the isodose on the right lower side is of brachytherapy. It's the best way to increase your dose on the target with a very sharp dose fall-off, and you got even better conformal therapy when you compare it with the 3D conformal or the intensity modulated or the art therapy. So for the selection of patients, it's crucial. It's crucial that you know where the tumor is, but even more important, where the tumor not is. So where you can spare the tissue. So mapping biopsies are crucial in combination with multiparametric MR imaging. So you see here the erased charcoal effect on the ventral side where the tumor is located. And ideally, you do it in combination with a PSMA PET so that you really can discover where the tumor is and where it not is. And there is a very recent publication on that. When you combine all the 3 diagnostic modalities, that you really increase your area under the curve, so that you can predict where the tumor is and where not. What are the indication settings for focal therapy? In primary setting, it should be located so solely to the prostate, of course. So ideally, a unilateral clinical significant prostate cancer. Clinical significant, that means Gleason score 3+3 in at least more than 30% of the tumor, and with a PSA lower than 20. And you can also treat Gleason 3+4 or Gleason 4+3. So it's the ISUP 1 to 3 criteria. When you detect like clinically non-significant tumor, like Gleason 3+3 or lower than 30% of the tumor, that is mostly the group that can be treated or can be in the group of active surveillance. So if you detect that at the contralateral side, it is not a contraindication in this opinion. So this is about the treatment planning that you see. You really can increase the dose to your GTV. So the GTV is here determined with, in this perspective, there is a margin of uncertainty. So because we know where the tumor was, and we know where he not is about the biopsies, but there is always an uncertainty margin in the focal therapy, because you are taking biopsies every 5 millimeters in the mapping biopsies, and especially at the suspicious zones on the MR and the PSMA PET, you can detect where it is and where it not is. So it makes it much more crucial than in a focal, with a focal implant than with a whole gland. A whole gland implant is relatively forgivable for your dosimetry because you're treating your complete organ. But here you see that if you are a bit too small in your dosimetry, that you can underdose a part. So some recommendations if you want to start with focal therapy. Toxicity is still an issue, so that is the reason for focal therapy. In my opinion, you should do it in a targeted ablation, so not only strict to the hemi gland, because that is like an hypothetic anatomical border. You can treat the clinical significant tumor and the clinically non-significant tumor. You can take it in an active surveillance. The accurate localization, it's crucial that you have a very good multiparametric MR with PSMA PET and the biopsies. And the biopsies are ideally transperineal and not transrectal, because with the transrectal biopsies, you miss a part of your prostate tissue, so especially the ventral side. So you can't detect it very well with transrectal biopsies. And of course, it's ideally to do it or to perform it in a clinical trial. And according to European guidelines of urology, you can do it in a clinical trial. And nowadays, I'm participating in a prospective database. It's called the Jupiter Registry. So where patients are collected, and that we so on a prospective way collect data to treat these patients. It is mandatory that you really know what you are doing, so that it's not like to do it outside any clinical trial. So thank you for your attention on this one.